fine. Now we have to be careful what we say. How do you pronounce Paramit Yoshi International Award?
Yeah.
Paramit?
Yes.
Okay. It's 1 o'clock here in Germany and many other times in the parts of the world where you're listening to us. So I would like to begin our session for today. I'm welcoming all of you to the 8th IACAPAP Lunch and Learn webinar, which we conduct on a regular basis. And as you might know, we are kind of traveling around the world and making these Lunch and Learn webinars from different parts of the world. And today I'm very delighted to welcome especially our speaker, Matias. Matias is a medical doctor, a mental health specialist, and a very important person. He's a adolescent psychiatrist and an advisor on mental health and substance use on the Pan-American Health Organization. And he is the former director of mental health at the Ministry of Health of Chile. He designed the mental health action plan and directing the COVID plan for mental health and the Saludablemente, I hope I pronounce it well, presidential initiative. And Dr. Matias is working in several research projects on diminishing stigma, building mental health and system treatment and research capacity, implementing prevention programs, and establishing a sustainable scale of public health system to improve access to mental health treatment in Chile and the Americas. And he received a very important prize, the Paramit Yoshi International Award from the American Academy of Child and Adolescent Psychiatry and the American Society of Hispanic Psychiatry Award for his contribution in global mental health. So he is, I think, the optimal speaker for our Lunch and Learn webinar. And he also covers a very important topic, which nowadays I feel is important throughout many, if not all parts of the world, which is the impact of economic crisis on child and adolescent mental health, a global call to action. Yeah, and with this, I would like to hand over to you, Matias, and end my slide here so that you can share yours and give your presentation, please.
Thank you very much, Christina, for the introduction and for the invitation. I'm very glad to be here with all of you. We are in different parts of the world. I'm now in La Paz, Bolivia, in a duty travel. It's 8 a.m. in the morning, and I'm sure that you have different locations, different time zones, and that's part of the global dimension that we have not only in work, but also the importance of thinking globally when we're thinking about child and adolescent mental health. So today I'm going to present about the impact of economic crisis on child and adolescent mental health. And I'm going to start talking about a world economic outlook, and then a little bit about the social determinants of mental health, because we know that SES and economy is one of them. The relationship between mental health and poverty, COVID-19 and economic consequences is almost impossible to keep out COVID-19 from our presentations and the analysis, but also in terms of some of the actions that the different countries are doing, the sustainable developmental goals, policy and individual intervention that the countries are doing or can be done, investment in mental health, and I will stop later with some conclusions and with some time to respond questions that you may have. Christina told me that and Sue that you may write questions in the Q&A chat. That's a way that we can later review and expand on the question that you may have. So I will start with a very short video to have a very brief world economic outlook update. I hope that you can see it. Sorry, that was a very quick economic outlook update. But we all know that there are several consequences of the stalling of the world's three main economic powerhouses, United States, China, and major European economies. And for many economies, the outlook has turned during this year, and the world may soon be teetering on the edge of a global recession only 2 years after the last one. And we also know that the baseline forecast for global growth is for it to slow from 6% to 3.2%. So that are very strong numbers in terms of what is happening in the world. But you may ask, well, what it has to do with mental health, and why we are talking about economists if we are mental health professionals. And there is a very important connection between mental health and different determinants that are not individual, but are in our families or society. Our mental health differs greatly depending on the circumstances in which we are born, raised, and live our lives. Those are social determinants. And this is because mental health is determined by a complex interplay of individual, family, community, and structural factors that may vary over time and that are experienced differently from person to person. Over the course of our lives, and all of us that work with child and adolescent mental health, we find ourselves on the mental health continuum that will fluctuate in response to changing situations and stressors. At any one time, a diverse set of individual, social, and structural factors may combine to protect or to increase the risk for mental disorders. Sometimes in our lives are more critical than ours. That's why early childhood is so important. But mental health conditions result from the interaction between individual vulnerability and stress caused by life events and chronic stressors. I think that all of these we already know, but when we're talking about the risk and predictive factors that determine mental health, there are several spheres of influence, but one of the least analyzed ones are the structural factors. As clinicians, we are usually talking about the individual factors or the family and community factors, but we most of the times don't ask or don't analyze the structural factors that may be important. And those factors relate to people's broader sociocultural, geopolitical, and environmental surroundings, such as infrastructure, inequality, social stability, environmental quality. These factors shape the conditions of daily life. The access to basic services and commodities, including food, water, shelter, health, and the rule of law is important for mental health. Security and safety are important structural factors, and prevailing beliefs, norms, and values, especially in relation to gender, race, and sexuality, can also be hugely influential. Historical legacies of colonialism influence multiple structural factors in numerous countries, especially here in Latin America, but in many other regions, as to climate and ecological crisis. So don't forget about the structural factors, which are so important. And then the question is, well, how mental health is related with poverty? Mental health is closely linked to poverty in a vicious cycle of disadvantage. This disadvantage starts before birth and accumulates throughout life. People living in poverty can lack the financial resources to maintain basic living standards. They have fewer educational and employment opportunities. They are more exposed to adverse living environment, and they are less able to access quality healthcare. These daily stresses put people living in poverty at greater risk of experiencing mental health conditions. Similarly, people experiencing severe mental health conditions are more likely to fall into poverty through loss of employment and increased health expenditures. The stigma and discrimination may also undermine their social support structures. They are vulnerable to a downward spiral of lost resources and social exclusion that can worsen existing mental health conditions and increase the risk of substance use, poor parenting, or failure at school. This then reinforces the vicious cycle between poverty and mental disorder. This is more the rule than the exception, with more than 80% of all people with mental disorders living in low and middle income countries, where the vicious cycle between mental health and poverty is particularly prevalent because of a lack of welfare safety nets and poor accessibility to effective treatment. And just to move from the numbers to the experience, this is Joanna's experience from Peru. I'm not going to read the whole experience, but I just highlighted one part that I think is important. Joanna is saying, I don't remember how old I was when my inner emotional conflict arose, but it was a long time ago. That's a very important message for child and adolescent mental health professionals. Very early symptoms. In 2014, I had the first of several crises, and so began numerous visits to psychiatrists and psychologists. I had to drop out of school because of excessive anxiety and delusions that never left me alone. My medication numbed me, and I couldn't concentrate. I lost a scholarship at a major university. I walked away from friends and family, thinking they would be disappointed in me. I locked myself in. I hardly went out. I cried every day, and I didn't have the strength to get out of bed. The idea of a successful future had vanished. You probably can imagine the frustration and also the problems that Joanna had during this period, having less possibilities to develop her potential. And in that way, there is a vicious cycle on that. If there is no treatment, if there is no access to treatment. And I'm not going to talk about the prevalence of mental disorders. We all know that is important, but talking about Joanna's experience, it's important to discuss the burden of disease related to mental disorders. Mental disorders are the leading cause of year lives with disability, accounting for 1 in every 6 ILDs globally, 15%. If we sum up substance use, 3%, and neurological disorders, 6%, combined, we have that group account for 1 in every 4 ILDs globally. The contribution of mental disorder to ILDs varies across the lifetime, from less than 10% for children and older adults to more than 23% for young people aged 15 to 29 years. And since 2000, both depressive and anxiety disorder has been among the top leading causes of all ILDs worldwide. 2 important risk factors came from the GBD study, the Global Burden of Disease study, childhood sexual abuse, and bullying victimization. Together, these risk factors, which are modified, account for 7% of all anxiety disorder DALYs and 10% of all major depressive disorders DALYs globally. That's why it's important to keep doing prevention. And suicide is also related with poverty. In this multivariable model that is shown in this graph, compared with countries with the lowest poverty concentration that are on the left, countries with poverty concentration of 10% or greater on the right had higher suicide rates in a stepwise manner. We can see that there is a adjusted incidence rate ratio of 1.37 for all methods of suicide and 1.87 for firearms suicide. So when stratified by method, firearms suicide had the strongest association with county poverty concentration in countries with 20% or higher poverty concentrations compared with the other countries. And we cannot keep COVID outside of the discussion because COVID has been so important. You know that the region of the Americas is the one that has the higher toll of death and also the higher number of cases in the world. And we are trying to manage here in Bolivia and many other countries a lot of children that lost 1 or 2 parents and that have lost also uncles and families, and that had changed her lives in a very important way. So in that way, a report in the Lancet provides the first global estimates of the impact of COVID-19 pandemic on mental health and suggests that 53 million cases of major depressive disorder and 76 million cases of anxiety disorders were due to the pandemic. So almost 30% of increase in anxiety and depression. And this study is the first to assess global impact of the pandemic on major depressive disorders and anxiety disorder. And COVID doesn't have to do also with health. We know that because of COVID, more people are without jobs, and more people are struggling with the economic consequences of COVID. And this is, again, an experience of a user, of a person from Ghana, Senam, and just to highlight some of the experience, saying that during the pandemic, she was unemployed at the time and did not have the funds for treatment. But my pensioner parents managed to make sure my medication were always refilled. I have been privileged to have a good system of support, but it's not the same for others. Some people could not afford treatment. It was and still is a very difficult time for a lot of people. The impact of COVID-19 on mental health cannot be underestimated. It cannot be made light of. And that's very important in Latin America and many other regions where the contagious curve maybe had decreased, but the but still we are having and struggling with a lot of consequences because of the pandemic. So we know there is a timely need for enhanced understanding of the role of economic factors at both individual and aggregated level. And it's also crucial that the effectiveness of intervention addressing these factors at the social and individual level is examined in relation to reductions in mental disorders. But we still have a lot of questions. So let me try to focus now on some of the solutions that countries are working to try to tackle the difficulties that we are having in this economic crisis. I will start with global collaboration. In second hand, making structural changes for mental health. And the third line of action will be protective factors to build resilience. So I will start with the SDGs. In 2015, all the countries in the United Nations adopted the 2030 Agenda for Sustainable Development. It sets out 17 goals, which include over 170 targets. These wide-ranging and ambitious goals are interconnected. For example, Goal 1 that you can see is to end poverty in all its forms everywhere, is related with other goals. And for example, it's related directly with mental health. It has, for example, a strategic line to about poverty alleviation interventions to people with mental disorders. Another line about providing welfare payments and financial protection to people and families with mental disorders. So this goal is important, but it's also cross-cutting, so that progress in its implementation contributes to progress toward other goals. And action on other goals in turn contributes to attain Goal 1. As you can see below, there are 8 other goals that are related with mental health. So we have 9 of the 17 goals that has actions in mental health. And all of the goals have indicators by which progress can be measured. But countries are already committed to addressing these realities through the SDGs, but the links between mental health and the SDGs are complex, and in many cases bidirectional. As you can see in this slide, there is a conceptual framework made at Krieg-Lund that summarizes the major social determinants of mental disorders that are linked with the SDGs. First, they identify the key domains of the social determinants of mental disorders on the basis of available epidemiological data. The domains were organized into the conceptual framework, and both distal and proximal determinants in each domain act on mental disorders mediated by family level and biological level, following Bronfenbrenner's ecological approach. As you can see, then we can link the social determinants of mental health with the SDGs, and in that way, link the targets that the SDGs and the indicators that they have with trying to tackle the social determinants of mental health. But there is also government policies and expenditure directed toward mitigating the impact of harmful economic circumstances that may not be traditionally regarded as mental disorder prevention intervention. But there is, for example, a recent systematic review of the study showed evidence to suggest that government unemployment support were associated with a reduction in mental disorder and suicide rates. It has important implications for suicide and mental disorders prevention. For every increase in unit of spending on active labor market programs, there is an associated decrease in suicide that can be almost 3%, especially in the older population. Another study investigated the impact of employment protection legislation in younger adults and found that those with regular work contract, there was a significant protective effect of legislation. This was also found in older age men. The average active labor market programs did appear to moderate the unemployment-suicide relationship in men, especially mid-age men who were in a central region in Italy, with a 1% increase in this program spending correlated with 0.5 decrease in suicide rates. And in another US study, an increase in the minimum wage of $1, only $1, reduced suicide by 6% in those with low education, using data from all states in the United States. So there's not only a global sphere, but also a more national, governmental sphere that can be used to try to prevent mental disorders using economic actions or strategies. And when we go to the another sphere, individual sphere, we know that in addition to government policies, there is a potential to provide tailored interventions for economic advice and assistance that may aid in the prevention of mental disorders and suicide behaviors at the individual level. Microfinance programs, for example, help the poorest earn a living, improve their business, and provide a means for entire communities to work their way out of poverty. And some studies, for example, examine the effectiveness of poverty alleviation tools and look at the relationship between small individual loans and mental health among adults in South Africa and in Kolkata, India. And the findings indicate that methods to reduce financial stress on poor and vulnerable adults are effective in reducing depressive symptoms among men, but are less effective among women. There's a small-scale feasibility study of a randomized controlled trial that examined the feasibility and acceptability of an intervention which provides psychosocial support for individuals who presented to the emergency department following self-harm or acute distress due to unemployment, financial or welfare issues, and showed that assertive intervention improved navigating the employment benefits and social welfare, increasing well-being. Well, there are many examples, and I will share the presentation with you, but it's important to know that all the action and strategy that we have discussed at the global level, governmental level, and individual level has to also be in line with an increased investment in mental health. The availability of dedicated financial resources for mental health is critical in developing, implementing, and maintaining mental health services and making progress toward the SDG goals. And according to WHO 2020 Mental Health Atlas, the annual global median government expenditure per capita on mental health was $7. Can you imagine? This is the median annual global median government expenditure in mental health, $7. And we know that most of the government expenditure on mental health is only 2% of the total budget. Over 70% of this expenditure was allocated to mental health hospitals, especially among lower and middle income countries. And over 80% reported allocating less than 20% of the expenditure in primary health care and mental health prevention and promotion programs. And almost 80% allocated no more than 20% to general hospitals and to community mental health services. So you can see there's not only a lack of investment in mental health, but also a distribution that is more focused on psychiatric hospitals. And this is a very quick slide, but can be important because not all the investment come or the funds come from the governments, but also come from this development assistance for mental health, which is financial and in-kind contributions transferred from global health channels to low and middle income countries with the primary intent to maintaining and improving health. As you can see, this is an analysis of the last 15 years. United States government provided 270 million of the total assistance for mental health, However, it was a private philanthropy that was the most significant source, accounting for 1/3 of the assistance. NGOs and foundation channels the overwhelming majority of development assistance for mental health. And most of the remaining was contributed by governments of high-income countries through bilateral aid agencies. As you can see, we as WHO are not the main financial source. We have a lot of donors, and with that donations, we can increase the support to the different countries. And I'm finishing with at least 2 case studies. And it's just to let you know that this can work. And this is not only theory. For example, in Jamaica, an investment of 115 million to scale up treatment for depression, anxiety, and psychosis between 2015 and 2030 has modeled an increased coverage of psychosocial treatment from 15 to 50%, and overall benefits of more than 400 million to the economy, including productivity gains and the value of wider social benefits and return, and also return on investment of more than 5 to 1 for clinical treatment. And in Philippines, an investment of 2.5 billion. It's a lot of population, but it's reflected in $2 per capita per year for integrated package of promotion, prevention, and care over 10 years, has shown that universal school, social and emotional learning intervention can prevent depression and suicide, and predicted to have the highest return on investment, resulting in $9 for every 1 invested. And other predicted high returns include the treatment of epilepsy, 6 to 1, and depression, 5 to 1. We have many other important cases, like in South Africa, Afghanistan, but I'm running short of time, so I will pass to yes, this last slide that shows that good mental health enables people to work productively and realize their full potential, that poor mental health interferes with people's ability to work, study, and learn new skills. It holds back children's educational attainment, which can impact future employment prospects. And meanwhile, adults living with mental health conditions may find that they're not able to work or cannot work as well as usual, often for very extended periods of time. And carers may be similarly affected. So as you can see, we are all connected in this cycle of protective or risk factors, and it's not only at the individual level. So we can conclude that reducing individual, community, and structural risk to mental health not only increase access to effective care, but improves well-being and social functioning, and also leads to a range of economic benefits for affected individuals and their household. Such actions can improve participation, productivity at school, reduce time spent on informal caregiving, reduce demand for health and welfare services, and increase the potential for savings or investment. And growing social and economic inequalities, protracted conflicts, violence, and public health emergency threaten progress towards improved well-being now more than ever. So the message is that business as usual for mental health simply will not do. And we should try to do things in a different way, and taking into account that we are in a global world and we need to work collaboratively. Thank you so much for your attention. I think we will have some time for discussion, or at least taking your questions on the Q&A chat. Thank you.
Thank you so much, Matias, for this very, very interesting talk. And I think all of us have many ideas about what to think about, and also the international but also national point of view on how economic crisis situations can affect mental health and how closely it is linked and how much good it does just to give a few or reallocate a few of funds towards mental health can make such a big difference is very impressive to my feeling. So far, I don't see any questions on the Q&A. Please, if anybody has a question, put your question on the Q&A and I will read it and Matias will answer it, I'm sure. But as long as we don't have any question, I will ask one, and which always interests me very much. It is the typical chicken egg problem. So my question is, on a personal level, is it that an economic situation or poverty produces mental health problems, or is it that mental health problems produce poverty on the other hand side? So can we or do we have data for causality, like from one direction to the other, or probably it's both, but is there any clue about what is more effective, which way?
Thanks, Christine, for the question. I think it's an excellent one, and it's one that it's been around for a couple of decades, because there are many people and policymakers trying to guess, well, what is first, how we can tackle this problem of poverty and mental disorders. And I think that we should try to make the analysis in different groups, because it's not the same talking about common mental disorders, like, for example, depression and anxiety, and severe mental disorders, like, for example, schizophrenia, bipolar disorder, or severe depression. I think in the first groups, the common mental disorders, we have more the chicken and not the egg causality, because it's more related about all the social determinants. If that person is going to recover, is going to support, is going to be resilient enough to advance in their lifetime. But in the case of more severe mental disorders, we know that it could probably be the egg, because we know that most of the times people that has a mental disorder doesn't have the access to care. For example, in schizophrenia, we know that the gap, the treatment gap, is over 80%, and in bipolar disorder is 70 to 80%. So most of the people that are having severe mental disorders are not receiving treatment. And for all of us that has worked in psychopathology, and we know that there's a complex effect in the brain, in the potential, in the windows of opportunities that are lost if we wait so long until the treatment. So in that case, that group really lost the capacity to express the potential and try to end the school and start working as the rest of the population. So I think that we have both situations. It's a bidirectional cycle, but we should try to do the difference between common mental disorders and severe mental disorders. The last ones are the ones that probably has the more important consequences in terms of reducing the potential of the person.
Thank you so much. We have two questions now. The first one is from Flora de la Barra, and she says, first, Matias, congratulations, very proud of your work. I think we can all agree to Flora. What is your opinion of the current amplification of mental health budget of Chilean government?
Well, thank you, Flora, for your question. And yeah, it's an important one. In 2020, WHO has the World Mental Health Day that it was dedicated to improve investment in mental health. And with the World Bank, we've been building the case to try to compromise countries to do this. And for example, in Peru, we had an increase in the budget in mental health from 0.5% to 2% in 3 years. So there are many countries that, with a lot of effort, are increasing the mental health budget. But in the terms of Chile, that is one of the high economist, high income countries in the region. The problem is that we have only 1.9% of our health budget dedicated to mental health. And the increase that was announced for this year is an important one, considering that we are in the middle of at least decrease in economic in Chile, but almost a recession in Chile, but it's still very low. If we do the math, the increase of mental health during this year in Chile is less than 0.1%. So we are very far away from the goal that the president and the ministry has of trying to duplicate or increase by 3 times the budget in mental health. So it's not bad news in terms that we are increasing the budget, but I think that in Chile specifically, we should try to look at some of the countries that did it very quick, because otherwise we're going to lose. Talking about windows of opportunity, this is also a windows of opportunity when you have a president that is talking about mental health, when in the agenda of the Ministry of Health, mental health is one of the 3 priorities. And when you have a high-income country, you can say, okay, let's try to do this. Let's try to close the psychiatric hospitals and advance and be an example in the region. But I think, Flora, that we should try to keep working with the government to try to do it quicker and stronger, because at least for this year, it's still very, very low, the increase in the mental health budget. Positive but low.
Thank you very much. And we have another very interesting question from Hanan El Masai. And it is, what about new solutions like mental health curricula in schools, telepsychiatry and therapy platforms and mobile apps?
Well, thank you, Hannah, for the question. That's a very good one, because when we think about these innovative or new solutions, we're thinking about trying to resolve some difficult situations, like, for example, the access to mental health. We know that the gap in terms of treatment globally is over 70%. So only 1 in 3 people have access to mental health care in the world. And that can be lower depending on the country and depending in the specific territories and regions of the country. We know that the countries can be very different depending on the geography. And with the COVID pandemic and many support from different donors, telepsychiatry and therapy platforms and mobile apps has been increasing the possibility of accessing mental health care. We all know that it's not the same. It's not the same to have a face-to-face interview than to have a phone call, for example, or a FaceTime interview. But for many people that doesn't have any possibility, can be the only way to access mental health care. Many countries in the region has included psychologists, has included psychiatrists in these telehealth or e-mental health innovation actions, and the result has been very good. So I think that the message is that it's a good idea most of the countries that are willing to do this, it's a good news that they can do it, but there can be some obstacles in terms of to really access the population that doesn't have, for example, mobiles or doesn't have very good internet connection. And at the same time, knowing that it's not the same, it's not replaceable as the interview face-to-face that can have with the psychologist or with the psychiatrist at a health center. So good news, but be careful with the implementation of the electronic or mental health solutions. Okay.
Okay, there's no other question on the FNQ, but I have a last one, if it's okay. And it might be a bit a provocative question, but I ask myself sometimes, and I lately came over it, with the energy crisis, the so-called here that we have in Europe at the moment, due to the war between Ukraine and Russia. Yeah. And I asked myself when I read a message from the president of my university that due to that crisis, the university has decided not to enlighten the university building at night between 12 o'clock and the morning anymore. And I thought myself, well, isn't it that we adults sometimes or many times take political decisions that not at all or that neglect the needs, interests, and also anxieties and worries of the very young people in our countries, because kids and school kids, adolescents, they go out every Friday on Fridays for Future, they demonstrate against climate change, but it needs something like a war and a so-called energy crisis to take us a decision not to enlighten a building at night. Yeah, and I could imagine that this also accounts to other problems like economic problems.
Yeah, that's an excellent thought, Christina, and I think that that's one of the messages that the children, the ones that we are usually trying to support, are telling us. So don't go for the easy solutions. Don't go for the static solutions. This is much more complex, much more deeper than turning off the light of a university during night. So it's good news that we are having very good ambassadors that are children, that are young people, and are permanently refreshing us that this is not business as usual. This is not something simple that can be just discussed. We need very determined actions to try to do the change. And that can be very important, Christina, because one of the most important threats for the population it's climate change. So we today speak about economic crisis, but it's also related with climate change. And that's something that when we are traveling and visiting the different countries in Latin America, it's a huge problem that includes migration, that includes mental health in all the aspects. So I agree that we should try to do everybody in a very specific individual way something to change, but don't be easy or tranquil about very, I don't know, easy solutions, because with complex problems, we don't need easy solutions. We need cooperation, and we need a complex solution. So that's an important issue, and thank you for discussing that, Christina.
Okay, thank you so much, Matias. It was wonderful to have you on this webinar, and I quickly share my slides because we have some other things to pronounce. Okay, I think it's there now. Yeah. So first of all, if you would like to have a certificate for your attendance today, which we can provide to you, then please complete the survey that you will find at the end of the talk now. And secondly, of course, we want to raise your attention to the next Lunch and Learn webinar, which will happen in January. And our speaker will Anna Thorup from Denmark, and she will cover a also very interesting topic, which is family and high risk for schizophrenia and bipolar disorder. How does it affect the children and families, and what can we do? So this covers the topic of children of parents with mental illness. And I think it's also a very important topic which is neglected many times. So children with parents with mental disorders are at high risk of developing a mental disorder themselves, but also they might be raised under very difficult circumstances. And Petrus de Vries from South Africa will host this session. So you're very much invited to sign up for this webinar and take part, and also inform other people who might be interested in that. And yeah, of course, we also would like to invite you to become an individual member of IACAPAP. That way you will be informed directly and have access to all our resources. You have lots of benefits from that membership, and we are able to reach out to you on a direct way, not only through national societies, which are important, of course, too. And lastly, I would like to raise your attention to a very interesting and important happening that will come up soon in December. We will have our international conference, our biannually, and it will happen in Dubai, in the United Arab Emirates. And we would be more than delighted to see you all in person there and to get to know you. So I think this is all the topics. Thank you very much, Matias, for being our speaker today to give us so many interesting insights. Thank you all for your attendance, and I wish you a good day and a good rest of the week. Thank you very much.
Thank you, Christina. Thank you, Sue, for all the organization and all the attendance. Have a great day.
Yeah.